Aloha. Dr. Mel Ona here, going live. So, it's about 12:35 p.m. Hawaii time, and I'm about to embark on this colonoscopy journey, unsedated. So, finished the prep. Everything looks pretty clean. That soup prep or souffle worked really well, worked much better. So, yeah, I'm looking forward to this. Looks like the doctor's about to come in. Hey, Michelle, how are you? So, again, sharing this journey. I did this back in 2018. Similar problem back then. I had some bleeding from below, bright red blood. This time was a little more significant, but again, no pain. Again, most likely something benign. I'm praying for that. But just going to check it out for due diligence. And again, for those who don't know, I am Dr. Mel Ona, and not only am I an owner of this endoscopy facility here in Kapolei, but I'm also a patient. Or how's it go? Not only am I the owner, but a client. Isn't it that hair? Isn't there like a hair commercial about that? But anyway, so gonna investigate this. And I decided to do it unsedated, partly because I've got work to do, partly because I drove, but mostly because I kind of like to educate and share that this procedure is very safe and relatively painless. Again, it's operator dependent, as I mentioned before. If you have someone that doesn't know what they're doing and shoves a long, flexible tube with a camera inside from below, that can be very painful. But again, just you gotta understand that it's being gentle and being an expert at navigating the twists and turns of the colon. And really it's painful if you stretch the colon or distend it too much with gas. So I think the doctor will do very well at minimizing those types of maneuvers. But again, I'm just looking forward to seeing how it goes, and hopefully everything turns out okay. I feel good today. Again, I was able to finish the prep. Most of the time, people use a 1-gallon lavage prep, fondly called Go Lightly. But I used something that's less volume, about half the volume. It's called, it's soup prep, but soufflave. It must be new because the flave part, flav is the flavor, so there's a couple of flavor packs. I shared it live last night. I did half the prep last night and then half the prep this morning, and it worked really well. I could include poop pics, but don't think anyone really wants to see that. But cleared out quite well. So I'm getting ready. I'm in the waiting room, got in here, and waiting for the doctor to bring me in. So in the meantime, yeah, until I get wheeled in, maybe I'll sign off and then come back on again. But just maybe some background. So this ambulatory surgery center was built during the pandemic, actually, here in Kapolei, which is west of Oahu. We started as an office-based endoscopy clinic. We built this out as a 2-room center, and we were able to successfully convert this to a ambulatory surgery center where we do upwards of close to 3,000 procedures a year. It's pretty much myself and the VA, so they've been very instrumental in using the space to take care of their patients, and so we are looking to continue to expand and grow. But yeah, our first procedure was in October of 2020. Hard to believe that that's going to be 5 years this year. And yeah, we've been fortunate to serve a lot of patients this side of the island, and we've made some pretty incredible diagnoses in young and middle-aged and older folks, colorectal cancer. So that's sort of the bread and butter of what we do with the colonoscopy as a screening prevention tool, a cancer prevention tool, where we do the procedure to look for precancerous polyps or growths, and if we remove those ahead of time, we can prevent colon cancer. not a lot of cancers you can think of you can actually actively prevent, but most colon cancers start as these precancerous polyps, and so if we can detect them and remove them ahead of time, then that's sort of the benefit. So yeah, it's you probably know that not very long ago, guidelines for screening colonoscopy, the age was decreased from age 50 to age 45, and partly because the incidence of rectal cancer has been rising in younger people, and I have made diagnoses of that in patients, as young as 20. So it's really sobering to hear that, and we don't quite know why that is. You can probably think maybe it's something in our lifestyle and our diets and such, because it's not all tied to genetics. But that being said, I'm here not really for screening, but more for diagnostic. Had that episodes of about 3 or 4 days of painless rectal bleeding. As I mentioned yesterday, it doesn't take a lot of blood to fill the toilet bowl, so it can be really disconcerting. Anytime you see blood, it's never normal, but there was quite a bit more with some clots. So again, I'm hoping for the best, and we'll see what we see. Thank you all for joining so far. I'm in my gown. I have my locker key. Put my stuff away, but I'll be driving home after this. Yeah, we should be getting in soon. But this is what the one of the rooms looks like. Standard pre-op bay. Also serves as a post-op bay. But yeah, I can't believe you're watching, Michelle. What are you doing? You playing pickleball? So no action here yet. We missed you at Forte. It's a great indoor pickleball place in downtown Honolulu, where the old Walmart used to be. It's fun. We're gonna play. Good stuff. Very cool. Well, I'm sort of in a holding pattern, so I'm not sure if we're going in soon. I thought we were going in soon, but check in with me in a second. Hi, Lucia. How are you? I'll probably sign off, so I'm not just like hanging you guys here. But yeah, the waiting is always the hardest part. But so maybe to share a couple things about myself. So I've been in private practice as a gastroenterologist here in Hawaii since 2017. I've been in solo private practice since 2019, and we have been running out here on the west side of Hawaii, recognizing that there's a big need everywhere in Hawaii, and particularly the outer isles, but west side for sure, points west. And we built this ambulatory surgery center to do procedures. We do upper endoscopy and colonoscopy and flexible sigmoidoscopies. And hi, are we ready? No, I'm on Facebook Live right now.
They're trying to like make me change and all that kind of.
Oh, okay.
What do you want me to do? Just wait, right?
It's up to you.
I'll just wait.
Okay, you can wait. I'll see you. So yeah, and we also just built out, I think there's another Facebook Live a few weeks ago shared of our brand new 1,534 square foot clinic. We have our own clinic, which is really exciting. Hey, Charmaine. So yeah.
Okay, I'll get dressed later.
Okay, yeah, get dressed later. I'll see you. Thank you. Hey, Louis, what's up? So again, thanks for joining, everyone. As you can see, maybe from reading the description, I don't know if it's up yet, but I'm going to be getting this. Hey, Dr. Assistant, how are you? You're on Facebook Live. How are you?
Good morning. Good afternoon.
This is our Chief of Anesthesiology. There's Dr. Assistant.
Hello.
Hello.
How are you?
This
Good
is
to
like
see
my
you.
second father. I see this gentleman more than I see my own family. Love this guy. So we've got some. Yeah, no pain. No pain.
With your mouth smell? Yeah, very good. Thank
He's
you,
assessing my malampati.
No pain, no chest pain, eh?
For
Your
airway.
breathing is okay, yeah?
Breathing's okay. He's gonna check me out.
Yes, listening quickly. Very healthy heart.
Thank you.
Lub dub,
Lub dub, lub dub.
dub.
I think I was bradycardic. I think I got to keep exercising. So.
There you go.
How long have you been doing anesthesiology?
35 years.
35 years? He looks
1990.
35 years old. 1990. Wow. Yeah, he's our chief of anesthesiology. Love this guy.
You ready?
I am, sir. Thank you.
Good to see you.
Good to see you too, Dr. Assistant. Thank you. Thanks, Louis. Right here, buddy. Thank you. God bless. All right, we're going in. They're going to wheel me in, everyone. I never get old. Thank you. I'm losing my hair, Louis. All right, we're going in. So, thanks, Joe. I could put that away. Yeah. Oh, cool. Thank you. He's taking my ID. So we're going to be rolling in. Rolling in. I think I'm the last patient, so. How you doing, Chief? So, here we are. Here's our center. You can see our ambulatory surgery center. This is the room that we're going to build out soon. Hi, Christetta. You're on Facebook Live. Hi.
What's your important patient today?
That's our nurse. Hi. Okay. And we're going to be going into the room. Hey, this is where I work. This is the Ohana Suite. Ohana Suite. Hi, Sharara. Hi. How are you? Thank you. This is one of my best friends. This is, you know, Victoria. Victoria soon.
You want the regular
And
one or extra large one?
so she'll be teching.
The dishes on the bottom.
So there's a lot of stuff going on in here. There's a beautiful, nice 4K screen. It's not really 4K. The equipment isn't made for 4K. You can see it's more high definition. We have state-of-the-art equipment. And we have this module called GI Genius, which we were the first ones to use in Hawaii back in July of 2022, which helps with polyp detection. It's an artificial intelligence powered technology. And we have a lot of fascinating stuff. So it can be a little intimidating because there's a lot of machines here, and you see the scope up there. There's the umbilical, the scope's up in there. So
You want
Yeah.
oxygen, Mel?
I'm okay. I think I'll be okay. Thank you. They're just gonna monitor my
Yeah, just more.
vitals. So
Pulse oximeter, blood pressure, EKG.
hey, Charmaine, I'm actually gonna be unsedated, so I will. I'm gonna be live talking about this whole thing. I won't show any parts because, you know, they might ban me on Facebook or YouTube. So it'll be G-rated. It's just gonna be mostly the screen, and I can explain what's happening and how I feel. I'm actually kind of nervous a little bit, and I do this. I think I did 1,700 of these last year. We did about 1,700. So yeah, still always a little bit. You get a little bit nervous in general, but yeah. So again, this is just gonna make sure everything's okay. Pray that it will be. And yeah. Hey, Kathy. So thanks for joining, everyone. And again, I'll be putting this probably on YouTube, but really just to help people who are considering doing this procedure to really consider it, especially for screening. And it's going to start getting tight. So I'm just going to breathe easy. Take my blood pressure.
Sinus breathing. Can we do a timeout, Mel?
Let's do a timeout.
Birthday again.
So we have to know we have the right patient for the right procedure. So my name is Dr. Mel Ona, here for colonoscopy with the staff here. And I introduced him earlier, but the person doing this colonoscopy is expert in this, Dr. Joseph Manlolo, who's the chief of the GI at the VA. And I really appreciate Joe. He's a brother. So I appreciate him doing that. So just getting my vitals. I can feel the sphygmomanometer working. The blood pressure cuff was tight.
It's gonna be another few seconds.
A few more seconds, and then yeah.
There you go, 162.87. A little nervous.
A little bit nervous. See, I was actually 120 over 58 outside. I'm 167 over 80 something. I got nervous. That happens. It's called white coat hypertension. And probably talking too much. I'm probably a little bit nervous. So yeah, I'm a little nervous.
When's your birthday, Mel?
My birthday is May 10th, 1971.
Thank you.
Thank you. Hey Sherry, thank you for the prayers. Thank you. Thank you. Here for colonoscopy.
Thank you.
So, yeah. And again, most people will undergo sedation. That's totally appropriate and really the standard. Makes it easier for the endoscopist, easier for the patient. They won't feel anything. Typically, we'll use, here at least, we use propofol sedation. And it works quite well. It's very fast acting. Patient doesn't remember anything, not awake. And then they wake up once the anesthesia sedation is out of the IV, they wake up. So it's pretty, again, very safe, and you feel very good. You feel quite rested afterwards. Hey Regina, thanks for joining. Thank you so much. Hi Seema. Thanks everyone, wherever you are in the world, here to help me through this journey. Again, I appreciate all the staff here and helping out. Fascinating how to be on the other side of things, but again, I I'm humbled by it, and I'm hoping everything's okay. Haven't had any bleeding for the past week or so, yeah. Oh yeah, Joe, thanks. So I had about 3 or 4 days of bright red blood per rectum, several episodes per day, painless, some clots, but yeah, no other symptoms, no fever, chills, nausea, vomiting, and again, no pain down below, no pain in the belly. No family history of colorectal cancer. So, yeah. Thank you for the well wishes. Just checking my blood pressure again, so I'm going to use this other hand.
How do you like the paddles? Do you like them on the side, or
I like
do you
it
step
on
on this? Just keep it here, like this, just like this? Okay.
Okay, I'm going to get in position.
I think you turn to your left
And I
side.
turn to the left. To the
You
left,
want me
to
to
the
lower
left.
the light?
Take your time.
No, it's okay. Oh, yeah, probably.
Probably
Yeah.
lower the light.
Should I just remove the lead? I got to put the lead back on.
Oh,
Sorry, yeah. We do the EKG leads.
there you go.
Thank you. Okay.
There you go.
So we usually get into what's called left lateral decubitus on the left side. So
You're okay, Mel?
I feel good.
Okay,
Yeah.
there
Thank
you
you,
go.
Audie.
There
Thank
go.
you.
You're welcome.
And I'll be talking to you all like this, but I will also share with you the screen, as you can see right there. That's the screen. But in the meantime, yeah.
Gonna raise this up, or do you want me to wait a little bit?
Oh, it's okay.
Okay.
And I gotta usually put the lower leg has to be straight. Usually the upper leg is bent like a sprinter stretch, and then yeah, that's where it is. Here we go. Thank you all. Thank you. Thank you.
Do you want to scoot a little bit closer this way?
I can.
To me? Yeah. There you go.
Lift your head up again, Mel. There you go, sir.
Thank you.
Yeah, sure.
All right, we'll be getting started shortly. And usually what we start with is, since I'll be awake, Dr. Manlolo will be doing the all-important part of the physical exam called the rectal exam, and so he's going to be inspecting and making sure that there's no, not painful. It shouldn't be painful, and just checking to make sure, there's no masses or lesions. Hey, Emmy. So, and then once we get started, I'll show the screen, and we can kind of go on the journey together. How you doing, Joe?
All right.
Thank you. There you are. Thank you. I am.
For the rectal exam.
Thanks,
All
Joe.
right.
Thank
Here
you.
we
He's
go.
about to do it, so he's gonna feel a bit. No pain, just some pressure. Just some pressure there. Yeah, some pressure, but no, not painful.
Okay.
Thank you.
That's fine.
All right. So now, thank
Here
you.
we go.
We're gonna go in. Okay. So we are in, he just put the scope in. Again, you're going to probably see a lot of water and such, but again, what it feels like, it just sort of just feels like you have to poop because the scope is, in that area, so it just feels like a big turd. But, most of the time is just trying to get in, going through the curves. Just went to the rectum. Again, there's curves. This is the sigmoid, which is really the curvy part. And you can see the wall of the colon is pretty smooth. And you can sometimes actually see vasculature, which is normal. You want to be able to see the wall is translucent, right? You can actually see it's thin-walled. And so he's going through so far, it looks pretty clean. He's using water and he's going through. What does it feel like to me? I don't feel any cramping right now. He's going through maybe like slight feeling of like almost a little slight cramp. Again, it just feels like I have to poop, a little pressure, and I can feel a little bit like a cramp. There you can see the wall of the colon. Probably, going through hard to tell where we are going in. There's a little diverticulum there, like a little pouch there. He's taking a picture. It's a little outpouching, diverticulosis. I had that the last time. We might have more as we get older. And, as he goes through the curves, this is where you sort of feel like things are a little crampy. But, again, not really painful at all. It's just, that just discomfort, a little uncomfortable. So as we go through, we'll kind of keep going. That almost looks like a little cramp, like the colon is sort of closed off, right? And as it opens up again, he'll be able to proceed all through the nooks and crannies. So far, so good. Again, I can feel a little bit of like that cramping pressure, but nothing majorly painful per se, no sharp pains, nothing that's going to make me scream in agony or anything. So, but everything seems to be okay. So the wall of the colon looks smooth. I don't see any ulcerations. We don't see any masses or lesions so far. No polyps per se. Everything looks good. We're going in. Oh, thank you. So we're probably in the transverse colon, probably. And, again, he's doing a great job navigating in. This is what I do also, just trying to get to the next sections. Trying to get to the right side of the colon, which is, I feel that feels a little, like, uncomfortable. But, again, just going to breathe through it. And nice and easy. He's just going to navigate through. And, again, it's just sometimes you feel a little distension. You feel a little uncomfortable, but we'll just sort of get through it and sort of breathe easy. So thanks for watching, everyone. Hey Dan, how you doing? Hey Emmy. Hey Ron, what's up, Ren? Again, we're going through and checking to see if there's any major issues here. This is a little bit of a curve there. Yeah. A little bit tight there. So we'll just sort of easy try and get through that area. Nice and easy. Right here. Sometimes it'll help to. There we go. It's that's a big curve right there. You have to take a turn. He's gonna suction back. There's a little bit of residue there. Okay. And then he's going to try to suction some more stuff out. Yeah, there's still dirty there a little bit. Tried to keep it clean, but there's no major poops in there. Just some dirty water. Looks like we're in the transverse colon, I'm assuming. Or maybe we're making our way to the... Maybe. Oh.
A little pressure.
Yeah, I can feel it. Oh, I feel it. Yep.
Try to relax.
A little tight there. Yeah, here we go. We're moving. We're moving. There we go. Okay, I feel that. Trying transverse. We're trying to get to the... There we go. Okay, okay. All right, here we go. Hepatic flexure. That's hepatic flexure. Now on the right side, I can feel I can actually pushing my belly. I can feel it in my belly. He's gonna dip down now into the ascending colon. There we go. This is ascending colon, I believe. There we go. And we should be, this looks like we're about in the cecum almost. Hold on, hold on. Oh, easy. Okay, here we go. Oh. Okay, now we're gonna just settle in. This is like the right side now. We are right where we need to be. There's a little bit of residue there, but this is the, oh, I can feel, like, I can actually feel the scope in my belly. It's incredible. Yeah, that's a cecum.
Yeah, we have.
Just cleaning out.
So there's the orifice right there.
That's the appendix orifice. That's sort of the landmark that we need to hit. And then, hey Sue. Brave, yeah, it's all good. But yeah, I can feel the scope. I'm actually pressing on the right side. I can feel the scope. He's just cleaning up a bit. Thanks, Joe, for doing this, brother. I appreciate that. And we're gonna probably come out pretty soon. He's gonna start the withdrawal part, just checking everything. So, yep. Took a picture. Photos are good.
Yeah.
Oh, hold on. He got into the terminal ileum. I feel good, guys. He's looking at my small intestine. He got into the small intestine. So, yep, you can come out. And now we're gonna start coming out.
Did you start the timer?
He's gonna do a timer. He's gonna have to.
Yeah, there's a button that goes on there, but that's fine. I think.
He's gonna withdraw from the colon and spend a minimum of 6 minutes. So, hey, Karen. Yeah, thanks for joining again. Remember back in 2018, right?
I'll just look at that one.
So, we're gonna try to check everything in the next 6 minutes or longer. Just make sure everything is good. So, thank you so much. You can see that's the ascending colon. You can see where the cecum was up here. That's the ileocecal valve that he went into to get to the terminal ileum, which is the end of the small intestine. And he's taking, it's kind of a curvy thing, right? You're gonna come back and see the hepatic flexure, which is the right side. So my prep isn't terrible, but it wasn't great. Apparently there's still some residue in there. I probably had some.
It's a good prep now.
It's not too bad, yeah. Thanks, Joe. You're being kind. It's good. I can see a lot of my patients did better. I think Dr. Assistant's prep was 10 times better than mine. So, wow, so much better.
Yours is a good meal.
Okay, I can feel it. There's a hepatic flexure. You can see the liver that's like a bluish hue there. So, yeah, and again, what it feels like right now, it feels like just a little bit of cramping as he goes in, because that's where the stretching of the colon is. And, you know, you get sort of waves of cramps, but not like, doesn't take your breath away per se. So you can hear me talking. But he's just checking all he's going in and out, really wants to check. It's called working the folds. He's got to get all those folds. He's got to look behind, clean out all this residue so he doesn't miss any potential lesions and polyps, particularly flat polyps, which can be hiding. So, yeah, he's checking it out. Sometimes the lumps and bumps can look like polyps too, but he's doing a great job looking. You can see the vessels, yeah? Like I said, it's almost translucent. You can see vessels through. And, yeah, so really good job, really checking everything out, working the folds. So we just went probably in the transverse colon here. You can see it almost looks like a triangle. Doesn't always look like that, but there are 3 longitudinal muscles that run the length of the colon called the tinea coli. So that's where you can get that triangle view. So, but we are in the middle of the colon, the transverse colon. And again, it just feels like I have to poop right now. Hey, Bethany, how are ya? How you doing? I mean, literally, that's what it feels like, because there's a long tube that's in the anal canal. It feels like the longest turd of your life, right? So that's what it feels like down there. And then my belly feels fine. It's soft, but, you know, again, I feel a little cramping once in a while as it gets distended. But yeah, you can hear me talking, trying to give you the play-by-play. Those are all the folds. Doing a great job. See, this is the vasculature there. Joe's doing a great job. I love what he's doing. He's really checking the folds, washing with the irrigation, really looking at inspecting. Really nice. You can see the shoots water in there. It's good. Yeah, really good. And intermittently you might see like this green box. That's the AI. It'll detect things. It could be just pieces of stool. It could be mucosa that's a little bumpy, but that's where the AI helps. So we're just looking. Yeah, I don't think so either. It doesn't look like anything. So he's just checking everything. Hey Tom, how's it? Thanks for joining. So far so good. From what I can tell, everything looks a-okay. Everything feels good. Just gonna clean me out. I was thinking, what should I eat after this? I was thinking maybe sushi, but I don't know. We'll see.
And then here, here's a tiny polyp here.
Yeah, you want to try a cold
Actually,
snare?
let me use the snare.
Yeah, I would use a cold snare. So you can actually see a polyp here. See the green? There's a green box there.
We call it transverse.
In my transverse colon, there's a little polyp. It may be precancerous. Hard to tell until we send it to the lab. So the AI is keying in on it. The GI Genius, it's called. So, yeah. Again, we were the first group in Hawaii to use AI. So we're really excited to use it. It has been shown to improve or increase the adenoma detection rate. So really cool that we're able to do that.
17%?
Yeah, my ADR. Not quite 70%, but maybe 50. So you can see there's a snare here. There's like a little bit of a tool that comes out, and he's gonna open up the snare. There's like a little wire, and he's gonna go around it, get a good margin, and then he's gonna have them cut, so you can cut the polyp out.
Yeah. Hold on a second.
So, and when you cut the polyp out, you can be rest assured that you can prevent it from becoming colon cancer.
Yeah.
So, looks like he had a pretty good cut. He's going to try to get a little bit more.
Yeah.
So he was able to slice it off. So he was able to get that polyp. He's going to suction it off.
Cap is on.
Yep.
So able to retrieve it. And we'll send it to the lab, and then, of course, we'll make sure that there's that the polyp is not precancerous.
Yeah, let me get the snare again. I'm going to take off more from it.
He's going to shave off more. So,
Yeah.
hey Randy, what's up, buddy? Haven't seen you in a while, brother. Thanks, Bethany. Yeah, right. Kind of an intimate view, inside and out. Thank you so much. Hey Aaron, what's up, buddy? Sorry, I'm just gonna put this back on. Thanks, Saudi. My lead keeps coming off. Randy, buddy, haven't seen you forever. So you're just gonna take another bite just to make sure that we get that little polyp there.
No, I want to get more on the
Yeah, I agree.
side,
He's gonna get more margin.
but yeah, let me just get into the right orientation. Here we go. All right.
There.
circle
So that's
slowly.
that's
There we
actually
go.
good. So now he's got a rim of normal
Yeah,
mucosa,
go through.
and he's able to cut that right out. So he got it.
All right, that's good. Actually.
That's
Yeah,
beautiful.
yeah.
That's
I like
nice. Awesome job. Sweet. So I can be rest assured that if that is precancerous, then we took that out and could prevent that from becoming cancer. So Oh, sorry to hear it, Randy. Diverticulitis can be really painful, man. So I'm glad that, I hope that you recovered. Sometimes it can come back and, you know, it can be recurrent. So thanks, buddy. You too, my friend. Randy, miss you, man. Love you, brother. What a beautiful family you have, man. So wonderful. How many kids you have now? I think 3, 4? Wonderful. So awesome. So you can see just kind of pooling here. I'm gonna take all that prep out. It's doing me a favor by making sure I don't have diarrhea later. So yeah, I appreciate all of you joining. Again, I'm humbled by the support, and again, I appreciate you all. You're like family. So, and yeah, again, I'm overwhelmed by that. So, still cleaning out here. I feel good. Probably approaching the splenic flexure soon.
Correct.
Yeah. Coming to the left side of my colon, I can actually feel things becoming less pressurized. And you can see the water is pooling on the here. I'm on my left side of my body, right? So it should be pooling at the bottom soon as we get closer to the descending colon, which is on the left. So I agree, Randy. True friendship never loses, even with distance. It's feel like anytime we talk, we should catch up. It'll be like those old Watertown days in Massachusetts. Crazy, right? So yeah. So here we're in the
Red 40.
about 40. We're about the descending colon, about 40 centimeters.
Yeah.
So the colon, typically about 4 to 6 feet. But in terms of centimeters, we usually get up to around 80 centimeters, halfway, 80 to 90. So, and when you're around 40, this is probably right around the descending colon. And again, you can see the folds. You can see this is more of a straightaway here. And then as we get down towards the sigmoid colon, it'll be more twisty and be more curves. So, okay, I can feel that a little crampy as we go back in, but he'll be coming back out. Yeah. So, yeah. So far, so good. Everything looks good. Little tiny diverticulum right there. Yeah, we call them ticks. Little tick. Yeah, Randy, sometimes, so diverticulosis is the condition of those outpouchings, but if you suffer from diverticulitis, you can have inflammation where you get this micro perforations, holes that cause inflammation and pain, and some people have to go to the hospital and get treated with antibiotics. So best thing is to eat more fiber and drink enough water, pay attention to gut health. And yeah, I think this is never had diverticulitis, but I do have a little bit of those diverticular disease. The air is off, right, Victoria?
The CO2?
Air. You see where it says air? It should be on standby or off. It should be off.
It's on standby.
Okay, perfect. That's perfect. Thank you. I just want to make sure. Yeah, sometimes CO2's on. Yeah. So we use CO2 to insufflate. You can see the colon is now distended. The good news is the CO2 will actually will diffuse, and then I'll blow it out. So there's another small polyp right there with so he'll be able to take it out with what forceps, which will take a bite. Oh no, Randy, you had a perforation. Oh no, sorry to hear that. That's scary. Yeah, that's a hole. That's like a full hole. That's scary, man. Sorry to hear that. So
Your home stretch, Mel.
we're in the home stretch, everyone.
Yep. This one's a little sharper, right? These orange ones.
Or was it?
Are these orange ones a little sharper than the blue ones?
Hey, Melvin, how's it going, Melvin?
Yeah.
How's the pickleball going, brother?
I'm used to this orange one day.
So the tool he's going to use now is forceps. So it looks like little teeth. You can see. He just pulled it. He just grabbed it, pulled it out, and took out that small polyp. And that polyp's probably about a 1 to 2 millimeters in size, really small. So it looks much bigger on the screen, but that's definitely only a millimeter or so. Hey, Melvin, yes, excellent assistant. Yes, thank you. But we're on the home stretch here, just getting rid of more water, and we're in the sigmoid colon, which is the last segment of the colon before the rectum, and we should be out fairly soon. Yeah, so far so good. I think we're already in the rectum almost, right?
Yeah.
Yeah, so this is the rectum. This is the end of the line here. And so he's, yeah, a little pressure. He's going to do what's called, he's going to do a selfie, a rectal selfie, basically doing retroflexion, where he's going in and doing going to do a U-turn inside the rectum. Sometimes it's a little narrow. And you don't necessarily have to do it. If you just want to stay, just do it from, if you want to stay.
You feeling it, Mel?
A little bit, but it's okay. Yeah, I'd rather somebody just do it. We can just stay straight. If you want to just do straight up, I'm okay with that. I'm okay with that. You can see there are some hemorrhoids. You can see some hemorrhoids here at the edge. Yeah.
I know it's uncomfortable when you're awake.
Yeah, for sure. I know.
But I feel I have a good look, actually.
Yeah, I think you have a very good look. So
Okay. All right. Here we go. We need to suction out.
he's gonna suction out, and then we're all done. That's it, my friends. Yeah. Thank you so much. That's it. Woo! All done. Thank you so much. That was awesome. You know, there were some times where like my colon was a little bit twisty and turny. Felt a little more crampy there, but I was able to talk through and breathe. And yeah, Dr. Manlolo was able to take out a couple potentially precancerous polyps. So wow, that's a good find. Thank you. So pretty much that's it.
I'm gonna lower you down.
Yeah, sure, Karen. So the aftercare following the procedure. So again, most folks who are sedated, they'll be awake actually right after they finish the procedure. And again, what they'll do is we'll go to the recovery, and it usually only takes about 15 minutes or half an hour, depending on sedation. Some people will use the conscious sedation, which sometimes lasts a little bit longer, takes a little longer. Things like midazolam and fentanyl. If someone says, sort of twilight or conscious sedation, those medications sometimes take a little longer for onset. But anyway, the aftercare will be, you basically recover. You get just, if you are sedated, you don't want to drive, you don't want to make any major decisions. That's why you take the day off of work. Because I was unsedated, I'm actually going to go work now. But yeah, you have to have a chaperone, someone to drive you. That's the policy of all these places if you have sedation. It's just for safety. No one's trying to make it difficult on you. So if you don't have a ride, you're really not going to be able to be sedated. So make sure you plan that. And then, yeah, usually hope that's answering your question, Karen. That's an excellent question. Yeah, you're welcome. Thanks, Randy. Let's catch up soon. Thanks, Charmaine. Yeah, it went well. I appreciate everyone. I feel good. I feel better so the bleeding was likely caused by hemorrhoids, I'm thinking. But look, now that we have this etiology, we have the reason, at least now, if these are precancerous polyps, potentially we'll need to come back maybe in 7 years, maybe 5 years, maybe 3 years. It depends on the type. So we'll see what that report comes out as. So, but thank you all for your time. I'm gonna get ready to go home, and or actually I think I have a work meeting now. So, but I want to thank Dr. Joe Manlolo. There you are, Joe. Thank you so much. That handsome guy over there. God bless you, man. Thank you. Appreciate you. Appreciate you all. Take care. Thanks, bacteria.
Yeah.
See you. See you. God bless you all. Bye.